You're listening to the second season of Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to the second season of Medscape's In Discussion series on type 2 diabetes. Today we'll be discussing heart failure and diabetes. First, let me introduce our guest. Dr. Butler is a senior vice president at Baylor Scott and White Health in Dallas, Texas, and distinguished professor of medicine at the University of Mississippi in Jackson, Mississippi. Welcome, Javed.
Great to be here. Thank you so much for inviting me.
Oh, it's my pleasure. First of all, I really like to have a little insight into my guests. And one of the questions I've always had for you, Javed, is what led you to seek a fellowship in heart failure when you were looking at your options?
You know, it's actually a really interesting question. So, many folks have sort of, much more diffuse answers. I actually know the exact moment I became a heart failure doctor. I was born to be a hepatologist. I wanted to do GI. All my electives were in GI during internship, applying for my fellowship. And then as a second year resident, I was sitting in and somebody came from New York to New Haven to give grand rounds. And that was Milton Packer. And remember at that time, we were talking about the 1990s, the heart failure was not what it is today. And he talked about neurohormonal theory for heart failure. And I can tell you that one grand round changed my life. I mean, I was just like, wow. So then I sort of changed my electives, did some cardiology electives, and then, so many years down the road, here I am not only as a heart failure doctor, but now I work at the same institution with Dr. Packer day in and day out. So that is a pretty interesting story, at least from my perspective.
So you've actually had this conversation with him, I assume, that he knows the large part that he played in your life.
Absolutely. And he was so gracious when I told him this story. So yes.
Oh, that's wonderful. Well, I've been in this field for a very long time, and I, like you, have been very tuned in to cardiovascular complications of diabetes. But it wasn't until the EMPA-REG study, which was, as you know, published in 2015, that heart failure started to be on my radar screen. And obviously, I consider, like many, heart failure to be one of the stealth complications of diabetes because unlike the other things I frequently see, I don't have a clue when and how to be concerned about heart failure. And therefore, I think the first question that I would like you to answer is, what are the more subtle signs and symptoms of heart failure that we as diabetologists or primary care providers can look for to increase our suspicion of heart failure?
Yeah, so this is, such a critical question, and it's both an easy and a difficult question. And it's an easy question because the signs and symptoms for heart failure are really sort of very generic, right? I mean, we're used to dealing with these signs and symptoms all the time: shortness of breath, fatigue, tiredness, dyspnea, inability to be able to do things that you were able to do. And then if the heart failure is not diagnosed for some time, then inability to lie flat, waking up in the middle of the night, short of breath, all of those things, going to the bathroom more frequently at nighttime. So these are sort of the common symptoms. The problem here is that for the longest time, we have been focusing on prevention of cardiovascular disease, Framingham Heart Study, the lipid revolution going on from Framingham risk score, 1970s, 1980s. But the whole idea was that cardiovascular disease was equal to atherosclerotic cardiovascular disease. It was all about the coronary artery disease or vascular disease. And heart failure was a consequence of vascular disease. So if you would just focus on diagnosing, treating, and preventing vascular disease, you would prevent heart failure by definition. The problem is that while that statement is true only for a proportion of heart failure. And what we have learned over time, that a large proportion of heart failure, almost half of the heart failure, occurs in the absence of manifest vascular disease. I don't know whether people have subclinical coronary disease or not, but at least they have no history of angina, no history of MI, no history of stroke, no history of peripheral vascular disease. So there's no manifest vascular disease, and people develop heart failure, especially HFpEF. So one is that mindset that we need to broaden the concept of prevention or thinking about heart failure. The second issue is that heart failure with reduced ejection fraction is your heart doesn't contract enough. But when we talk about heart failure with preserved ejection fraction, you're literally trying to diagnose a disease that classically has required a normality in finding, right? I mean, you do an echo and the EF is normal. So that becomes pretty complicated in the primary care setting. So what people end up doing is that you rule out in person complaining of shortness of breath and tiredness all the common things: COPD, asthma, lung disease, hypothyroidism, anemia, and then you stop. And then what ends up happening is you don't bring heart failure as one of the things that you ought to be screening for. And you basically blame obesity or aging for patient symptoms, not realizing that 3 months, 4 months ago, you were equal weight and you were the same age. And now these are new onset symptoms that you need to be looking into. Therefore, the number one place where heart failure gets diagnosed is in the emergency room. Why? 80% of heart failure is diagnosed for the first time in the emergency room because the outpatient diagnosis has been delayed and ignored. And now a person shows up in extremis pulmonary edema. That's where the diagnosis is made. So this is a long-winded answer, is that the signs and symptoms are really common: shortness of breath, fatigue, edema, inability to do what you were able to do, your satiety, orthopnea. But the issue is not that the symptoms are rare. The issue is that we don't think about the differential diagnosis of heart failure.
So, do you have a question that you would suggest we ask our patients on a routine basis that might start teasing out some of these issues?
What will help, and many primary care practices do this already right now. So, we routinely do vital signs, right? So somebody doesn't have to have a complaint of, headache or dizziness. You will always do heart rate and blood pressure on everybody coming in. Some sort of a questionnaire as an intake form about tiredness, fatigue, shortness of breath will be very helpful because that will flag it. Otherwise, unless and until the patient actively complains of these things, we will not necessarily ask these probing questions. And what ends up happening is that right now I'm focusing on clinicians not necessarily taking these symptoms when they're mild to moderate seriously, but even the patients don't take it, right? So what patients end up doing is that they lower their expectations from themselves. So, I used to be able to walk 6 blocks. Now I am able to walk 3 blocks. I used to take care of everything at home myself, but now my son or my daughter helps me. So those dynamics come in. So when you don't ask them these probing questions, they may come to the clinic and they are quote unquote doing fine, and everything gets under the radar screen till it becomes a really big problem. So for early screening, having some sort of a questionnaire for these generic diseases would be very helpful.
Yes, and I actually find just asking patients, is there something that you were doing last year that you no longer feel like you can do? And you're right. A lot of times they say, oh, it's just because I'm getting older. They don't really think of it as being a significant change. Well, I think that really helps. Hopefully, the audience will take that and put that into their toolbox to help us identify our patients sooner. Speaking of that, as you probably know, the American Diabetes Association had a consensus paper that was published recently where they recommended that we routinely use biomarkers for screening for heart failure in our patients with type 2 diabetes. What's your opinion on that?
I think it has been long due. This is great step that the American Diabetes Association has taken, and I would hope that this will multiply and other societies will do the same. And the reason I say this is that for most diseases, quantification really matters. So, for instance, I'm a little bit shy about talking about hemoglobin A1C with you, but hemoglobin A1C is not perfect, right? So, you had a threshold of 7 and a threshold of 6.5. I'm sure many people with 6.4, if you were to do oral glucose tolerance test, maybe it's worse than what you are looking at hemoglobin A1C. But nevertheless, having some degree of a quantification to make clinical decisions really helps. And then the gray zone around that number, you can manage clinically. We have a number in blood pressure, we have a number in CKD, we have a number in cholesterol, whatever. When it comes to heart failure, it's only relegated to sort of signs and symptoms, and then it leads to all those issues that we just briefly touched upon in the earlier question. So I think that first, the data is incredibly robust of natriuretic peptide levels being high as a marker of cardiac stress. Now, the cardiac stress does not equal heart failure, but equals something. So, not ignoring high NT-proBNP is a great idea so that it can take you to the next level. Now, it may be aortic stenosis. It may be just uncontrolled hypertension. It may be just bad CKD. It may not be heart failure, but at least it sort of rings the alarm bells that there is something going on that you need to be looking into. So I think this idea that an annual assessment of natriuretic peptide in type 2 diabetes patients who are by definition at high risk for heart failure and not waiting too long that they develop florid heart failure and catching them earlier when they are at risk for developing heart failure to intervene is, I think, a great step.
So I think you answered my next question. So the pro-NT-BNP is the one that you would recommend that we measure. Do you have different cutoffs for going to the next testing level according to age or CKD status? Or would you say anytime the level is above 50 or 100, the patient should proceed with the next step?
Yeah, so at least my bias would be that if your BNP is greater than 50 or NT-proBNP is greater than 125, then I think proceeding with the next step is a good idea. Now, what is the next step and who should be doing that? One can argue from a cardiologist perspective, the obvious next test is an echocardiogram. Echocardiogram, remember, is one thing we do in medicine, ultrasound, that has absolutely just no risk. I mean, so there's no controversy, no risk, no radiation, no nothing. The issue then comes up is cost. So you don't want to do unnecessarily echocardiograms because you will multiply the healthcare costs. And that's why having some thresholds is a good idea. So if a diagnosis of heart failure is made, so the question is, if somebody has shortness of breath, tiredness, some lower extremity edema, something is different and you do natriuretic peptide, then you're thinking about diagnosis of heart failure. So in the primary care, you can do other things, rule out hypothyroidism, rule out anemia, those kind of things, and then send it to cardiology and echocardiogram, a one-time assessment, rule out, pericardial disease, valvular disease, rule out heart failure. And if there is no heart failure, then the person goes back into the primary care setting. If a person does get diagnosis of heart failure, then that requires a whole new evaluation for the cause of heart failure, and that can occur in cardiology practice. But if you're doing what you just said, which is screening NT-proBNP in the absence of symptoms, so now you're not talking about diagnosis of heart failure in a symptomatic patient, but potential strategies for prevention of heart failure. In that case, it's a little bit more questionable whether everybody should get an echocardiogram or not. So a person is completely asymptomatic going around with their life, but the natriuretic peptide levels are a little bit high. So that, I think I would individualize it. If somebody is older, bad family history, multiple risk factors, smoker, whatever, you might want to do an echo. But at least a strong risk factor modification and a strong consideration of SGLT2 inhibitor in type 2 diabetes patients with high natriuretic peptide levels who are really sort of a setup for developing heart failure, and with so much data on prevention of heart failure with SGLT2 inhibitors, that will be a good idea. But then one can argue whether these are hard numbers or whether we should sort of alter these numbers depending on the patient phenotype.
I think that's really helpful. So, if in doubt, what I'm hearing is it would probably be appropriate to get a cardiology consult if you're kind of on the fence about whether or not your patient has a diagnosis. Well, that is incredibly helpful for me, for one, in my practice. So let's talk about the medications and the continuum of care for patients with type 2 diabetes and heart failure. Obviously, there exists now guideline-directed medical care for patients, particularly those with HFrEF. And those patients, obviously, there are 4 to 5 classes of medications that are recommended, which of course include the SGLT2 inhibitors, with or without regard to type 2 diabetes diagnosis. So starting with the HFrEF, which I think is, again, as you indicated, probably about half and maybe slightly less than half of the total number of patients. Can you tell me how you go about staging the medications, starting them? Do you start them in the hospital? Do you have a specific guideline for how they are started and in which order and, all at once? Or, what's the timeline between the patient diagnosis of heart failure and the time you have them on the appropriate therapies?
Great question, and there are sort of several principles here. So first is that if you look at the last set of guidelines, both American and European guidelines, they were very algorithmic. Do this first, do this second, wait this long, watch for this. And this iteration of guidelines are distinctly different, and all of those things have just simply gone away. And there are several reasons for that. One is that, remember, sequencing is a historical construct, not a biological construct. It's history of medicine that ACE inhibitors were tested in the 1990s and beta blockers and ARNIs and SGLT2 inhibitor. But there's no scientific rationale that you have to prep the heart with one medication first before the second medication will work. In fact, there is plenty of data that if a medication works, it works irrespective of baseline therapy. For example, when Rawls trials was done with MRAs, beta blockers were not standard of care. Only 10% of the patients were on beta blockers. When Emphasis trial was done, 90% of the patients were on beta blocker, but beta blocker presence did not matter. MRA works regardless. We have the same data with ARNIs and MRA, with SGLT2 inhibitors and ARNI. So the sequencing concept is completely disfavored right now. Also, how can we have the same algorithm when all our patients are different, right? I mean, congestion, no congestion, atrial fibrillation, high heart rate, creatinine, potassium. So you have to individualize it to a given patient. Third is that the benefit with all of these therapies is seen within weeks of starting the therapy. And therefore, following a strict regimen and waiting for months on end puts patients at a high risk, and inertia sets in, and then you don't necessarily give the therapy. And then the fourth and the last is that doses are really important, but is of secondary importance. The primary importance is to cover all the necessary pathways with some dose, because introduction of the medication at low doses, you get the biggest bang for the buck, which doesn't mean don't go up on the doses. Definitely go up on the doses. But it's a bad idea to go up on the doses so much of one medication that you have no blood pressure or creatinine left for the other medication. Or you go up on one medication and it takes such a long time that the other medications are sort of never introduced. Now, with SGLT2 inhibitor, dose is not an issue, right? It's just one pill, 10 milligram once a day. With MRAs, dose is really not an issue. 25 of spironolactone is good enough. With beta blockers and with ARNI or ACE inhibitors, that is an issue. Also, we should, barring accessibility issue, the data are incredibly clear that ARNIs are the preferred drug, not ACE inhibitors. So it's really ARNI, beta blocker, MRAs, and SGLT2 inhibitor. I have absolutely no preference of which one you start first, but there is some edge that some drugs can help facilitate other therapies. So for instance, if you're congested, you're not going to tolerate beta blockers, but if you get an SGLT2 inhibitor or ARNI that have diuretic properties, your beta blockers will be better tolerated. If your GFR is borderline or potassium is borderline, you're not going to tolerate MRA. But reasonable data suggests that SGLT2 inhibitors will help facilitate MRA because they lower the risk of hyperkalemia. So you can sort of do this. So right now, the focus is whether you do it in-person visit, telephone visit, virtual visit, whatever, on a weekly basis or something. Just get all the 4 medications on board in any sequence and at least low doses in 4 weeks. And then you can sort of take your time going up on the doses as needed and as tolerated, but cover all bases in about 4 weeks or so. I am not a fan of starting more than one medication at the same time, because if the patient has some side effect, you have no idea which one did it.
That's really good. So the guidelines differ for HFpEF, preserved ejection fraction. Can you just briefly comment how that changes your practice and how you manage those patients?
Honestly, I mean, if you look at the details of the guidelines, the recommendations in HFrEF and HFpEF are actually almost the same. The difference being that the level of evidence is different, because in HFpEF, a lot of it is based on secondary analyses of the trials and not primary analyses. But the real difference, if you look at the recommendations, not worry about the level of recommendation, whether it's 1 or 2A or 2B, but what medicines are being recommended, the only difference is that EF less than 50%, it's quadruple therapy. EF more than 50% is triple therapy, and beta blockers are not recommended in patients with EF more than 50%. But I want to make it amply clear that that is for treating HFpEF. But a lot of these patients have coronary disease, MI, ischemic heart disease. So if you have some other indication to give beta blockers, by all means, give it to them. There's no contraindication per se. But for HFpEF, there's no indication for beta blockers.
I think this is a really important message because we see these patients, and I have a number of patients who have heart failure who are not on all the therapies. And I think I speak to them about, getting a heart failure specialist on board because their general cardiologist is not really doing the guideline directed medical care. So it is something that we as primary care and diabetologists can help our patients, get to the right place and get on the right therapies if we are aware of what the guidelines are. So really that is very helpful. As our last question today, so if the audience takes away one point from the discussion, what would you say that should be?
So I would say is that if you have a person with blood pressure of 180 or LDL of 180 or whatever, hemoglobin A1C of 9, you would never leave that person alone saying that I will treat this patient appropriately, aggressively when the person develops some symptoms. Remember, these diseases are by definition asymptomatic. And the whole idea is to treat to prevent complications. Unfortunately, for whatever reason, we think about heart failure as differently, and multiple surveys show that patients are not on optimal therapy. And when you ask the clinicians why, the first answer is that the patient is quote unquote doing okay. I mean, it's like basically saying that, your PET scan has lit up for cancer recurrence, but you don't have symptoms, so you're not going to treat, right? I mean, that's not the mindset. So please treat the patients early on to prevent worsening heart failure, sudden cardiac death, all of those complications. Don't wait for hospitalization. Now, of course, if somebody is hospitalized, they are at high risk and give aggressive therapy, but do it as early as possible upstream.
Javed, thank you so much for a great conversation today. We've talked about heart failure and diabetes, recognizing early symptoms, the importance of screening, the importance of treating aggressively once the diagnosis is made. I hope that this has been helpful for the audience. Thank you so much for joining us. This is Dr. Carol Wysham for In Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.